Okay, so we'll notice that I have the volume turned up a little high for this test lung, so 600. And what you're gonna see here is that your peak inspiratory pressure is quite high. So we're getting close to where you're almost gonna pressure limit. So you'll see that little 45 there as our alarm, but where it's actually gonna start pressure limiting your breaths is at 40. So when you get there, on that 40 there, you're going to notice that we're not even getting our full 600 tidal volume. So in this case, what we've set is likely too much for our patient. They could also just be really sick and have really sick lungs, but generally, generally if the PIAP is that high, we need to assess why. So in someone with like restrictive lung disease, you might get really high peak inspiratory pressures, but it's definitely not the norm. And what we can do is do sort of a lung protective ventilation. So we can turn down our volume. And we'll see, I'll go from 600 to 400. And then we'll see this number is going to drop. So we can also, other things we can do is turn down our PEEP. So that'll also give us less pressure and decrease our PIPs. So you'll see as we're giving less volume and we've dropped our PEEP, that our peak inspiratory pressure has come down from a level that would or potentially do lung damage to a reasonable number. And so the only thing we want to consider is if we're dropping our tidal volume from like 600 to 400, say, then we are going to potentially blow off less CO2. So our CO2 could climb. So what we often do is to also increase our respiratory rate. So for this alarm here, for now, I'm just going to make sure that this is under what I have set. So continuing on, so now that we've dropped, so we'll say we'll drop our tidal volume quite a bit. But our minute ventilation is dropping. So depending on what we want to set for a minute ventilation, and normal is between 6 to 10, we may have to increase our respiratory rate to increase that minute ventilation. And you'll see it's going up there. That being said, as we increase that, we also need to be mindful of our TI and our I/E ratio. So as we increase our respiratory rate, our I/E ratio went up. So what we can do is we can bring our TI down, inspiratory time, and now we're back to an I/E ratio of 1 to 2. We just want to make sure that that ratio is good, because if it is, say, 1 to 1, what can happen is you always need longer to exhale than you do to inhale. So if we get that to a 1 to 1 or even like an inverse ratio, what can happen is our patient can start gas trapping. And so for some alarm troubleshooting, if our minute ventilation is high, so here we have it set to like 14 liters a minute. So if our patient started like waking up and they were breathing a lot above the ventilator and taking really big tidal volumes themselves, what can happen is we could start getting alarms. So some of them can be a high minute ventilation alarm. You could get like a high respiratory rate alarm. And so what you want to consider then is, are we intending to wake up our patient, or do they need further sedation, or how can we manage? And then so in here, like, yes, we can increase some of these values if they're sort of like a nuisance alarm. but we don't want to just increase them and then ignore what's going on with our patient. So respiratory rate, you could increase a little bit. And then other things to consider are if you start to see your patient taking breaths, what you'll get up here is little lung splashing. So that means they are triggering the breaths themselves. And then you might see all types of like different patterns up here, depending on how much they're fighting the vent or how asynchronous they are. So that would be a time to discuss with the physician, do we need more sedation? What's our plan for the patient? Other types of alarms you can get is you can get high pressure alarms from the patient like clamping or obstructing the tube. So, or potentially if you were inline suctioning and you left like the suction catheter in the tube. So some of those alarms can come from those situations, which I would recommend then using, like going through the DOPE mnemonic. So anytime we have alarms and, you know, we're like working our way through them, it's a good mnemonic to consider. So that is just like D is the tube like displaced? Is it dislodged? Is that the reason for some of my alarms? Is the O is obstructed? So is my tube obstructed? The way you can troubleshoot that is you can try passing a suction catheter through it, see if it goes through freely. It can get obstructed if the patient doesn't have a bite block in and they're clamping down or biting the tube. P is, does my patient have a pneumothorax? And we know we can auscultate, we can see if there's unilateral chest movement. We can look for tracheal shifting, signs of a pneumothorax. And then for E is if all else fails and you can't figure it out as equipment. So that would be taking the patient off the ventilator and handbagging them to see if it's an equipment issue that you can troubleshoot easier once your patient is safe and being bagged. Good. If we're ready to turn off our ventilator, there's a start standby button here, or we can use this button here. And the only other button I should mention is this button here, is the alarm silence button. So when we have an alarm, I'll try to make one here. Okay. So we can silence the alarm by pressing it. And then you'll notice up here, it'll tell you how long the alarm is silenced for. So we can silence it, but we want to make sure we don't ignore the alarm. And then in here, we can, let's say we're ready to turn off the ventilator now. So we can press this button. You're going to see there's a standby. So you need to press standby, click. It's going to alarm because it wants you to make sure that you were intending to turn off the ventilator and put it in standby, sorry. So you're going to press alarm, click, and then now we can press it again, and then it'll ask you to please confirm that you want to shut down the device. You'll say okay, click, and turn it off.